we're good to go now.
Okay. So welcome everybody. It's Rob McHugh here at Colonie Police Department with Deputy Chiefs Jay Garachi from the Colonie Police Department and Deputy Chief Erin Kelly from Colonie EMS. So topic of the day, agitated patients, restraints, and sedation. There we go. So this used to be the slide that I would end the presentation with. And I put it in here because I've been doing this so long that this is just mentioning that we've been doing this for a long time. Nothing in here is really new. It just keeps coming up to the forefront recently with the events over the last couple of years. Disclaimers, we have nothing to disclaim. We are paid our salaries and that's it. So objectives, we'll talk about sedation, talk about physiology for restraint, what agitated delirium is now versus excited delirium for before, some medications, and then big part is just talk through some cases and see what the experts would do. So fight or flight, just remember this, thinking about this. This is both what's going to happen with you in some of the situations and what your patient is dealing with. So sensory disturbances, things appear larger, things appear smaller, things appear to move fast or slow. Hearing, you can be hyperacute or you can have trouble hearing at all because of what's going on. Tunnel vision, loss of motor skills, everyone, these are real things that can happen to you and also can be happening to the patients, which complicates your ability to communicate with them and keep them calm. So delirium, reduced awareness of what's going on. We deal this with between the 90-some-year-old with a urinary tract infection and the 18-year-old drunk or high person. So you're going to get this a large spectrum of patients. So why are they like this? Most of the time, when we're dealing with this, it's going to be to this extreme. It's going to be substance induced, cocaine, methamphetamines, cannabinoids, and this isn't just the synthetic stuff. The stuff you grow is getting potent enough that it can actually cause some psychosis. The synthetic stuff you can get into trouble real quick because it's not the balance of the agents that are in the plant. It's pure chemical that interacts very strongly with receptors and gets you quite combative quickly. Alcohol, everyone knows about the anchor drunk, psychiatric disease, and the big thing is that you don't know what's causing it, but they're always going to be arrested you. Crisis behavior, threat is always the people. What they're responding to is, are they having delusions? Are they responding to internal stimuli? Are they interpreting with what you are saying them through the lens of whatever substance they're under, which is complicating the situation for you? Can you tell the difference? Most likely, probably not. It can be psychiatric, sympathomatic, we also talk about cocaine, amphetamine, alcohol. Are they in withdrawal or are they acutely intoxicated? And blood sugar. Everyone's had a story of getting into a fight with someone whose blood sugar was 20. Fix that and you find out that they're a pastor and a priest or something. And also head injuries. Sometimes they're outward signs and sometimes you may not have a gash on the forehead to clue you in. Medical versus psychiatric. Basically, the sum with this is you may not know, so you just have to treat them all basically the same. So how to keep yourself safe with this? Don't play in delusions. Everyone's thought it was funny to talk about the bugs that are crawling on the wall, that they're going to start falling onto you too. It never goes well. It's more for a comedy channel episode than actually with a real patient in front of you. Stand back, give people some space. One is it gives you a buffer if they try to lunge for you. It also makes you less of a threat to them. So it's easier to talk to someone when they're not getting their guard up. Bright lights, that goes without saying. Slow down. If you are getting amped up, your speech is getting amped up, and they can tell. Even what other substance are under, they're still going to be able to tell that you're getting amped up, and it's going to wire them up too. It's like little kids get upset when the parents are getting upset. It's the same idea. And try to designate one person, either the person who was initially there and establishing a rapport, or someone who comes in and seems to be better with this. If you have kind of the whole peanut gallery chiming in, you're all trying to help, but in the end, it just ends up confusing someone even more. Keep it slow and don't hide your hands. So risk, who you're going to deal with, these are all kind of self-explanatory. Men, almost always more than women. If they've been violent before, they're probably going to be violent now. Sorry, this is an old copy of an old slide for hospital thing. Arriving in custody police, so you're not going to be arriving with them, they're going to be there with you. If you're a victim of violence, you're more likely to become violent because it's what you know. Drug abuse and psychiatric disease as well. So what can cause it? Clearly the 90-year-old with the urinary tract infection, but sepsis, meningitis, diabetes, stroke, probably not acutely, but over time you will get dementia from that. Multiple medications can make you delirious, but then trauma, hypoxia, and the toxicology, the bath salts, the cannabinoids are some of the big ones to deal with, and then cocaine, amphetamine, alcohol. De-escalation. This is the big thing. We don't want to go hands-on. We don't want to have to sedate people if we can just talk them down. So control the area. If you need to turn the radio down, whatever you can do to calm the situation. Family members, this you have to be careful with, because some can be the trigger of the situation and act like they're trying to help now, but you don't know what the history is. So if they seem like they're helping, use them. If they seem like they're hurting the situation, don't be afraid to have someone step out to get some more history from them or something else, just so they're out of eyesight and out of earshot to if they're causing problems. And understand how you are. If you can stay calm and converse with someone who's not in full control of their faculties, then go ahead and do that. If you're someone who starts getting amped up and starts looking for a fight, then recognize that ahead of time. So make a deal with your partner that they're the ones that try to talk to the situations and not you. So basically, similar for all the situations deal with it. There's some confusion, agitated, and then people start to fight. And when you do, don't be surprised that this little scrawny person ends up having a lot of strength to them. So every situation, whether this is your grade on your high school chemistry test, your relationship with your spouse, and combative patients, all end up on a spectrum. Every once in a while, you get someone who is very pleasant. Yes, here's my other wrist. You can put the rest of the cuffs on. Thank you very much. Typical unpleasant verbal response to being cuffed. And then we get this guy. And this is where I wish we were a live audience, because I can see about half of the group looking out saying, what is this of? And the other half are laughing hysterically because it's up there. We're dating ourselves. Monty Python, Holy Grail, required viewing for all pre-hospital and emergency providers. So this is the Black Knight. This is, you lop his arm off, and what do you mean? It's just a flesh wound. The point being with this is, at this point, there's no negotiating. This is when you're this combative, all the holds that you were taught before, all of the self-defense things, they don't matter. They're just going to keep fighting. And when you put them in restraints, most people, when you lop their arm off, they would stop the sword fight. When you put them in restraints, you cuff them, and they're still fighting you, this is when you're back Black Knight territory. They're just not going to stop. And this is when you're into that. You're in the other extreme. You've gone from, thank you, officer, here's my other wrist, I enjoy having bracelets, to you're in a fight because they're not going to stop no matter what until most of the time they get medicated and then calm down. But this is when EMS and police definitely interact the most. So presentations, delirium with agitation, if they're sweaty, high body temperature, and high body temperature and dry as well. If you're doing painful things to try to get them pinned down and they don't seem to be responding to that. And then you pay attention to respiratory compromise. A lot of times they'll be hyperventilating, and anything you do to kind of restrict that can get you in trouble, which we'll talk about later on. So this is a case. So these are some films we're going to show you. This is a few years ago in Palm Beach. It's in the educational value of having cops and night watch riding along. The videos you get for interesting situations is great. Unfortunately, this had a bad outcome, which we'll see. There we go.
I don't know if there's sound, Dr. McHugh, but it's not coming over.
What's that?
Your sound.
People getting the sound after that?
No.
Okay. So put you on the spot. What were you seeing in there that's not normal?
What I saw in that is that he's not completely dressed. Granted, it's West Palm Beach, Florida, so it's probably warm enough for him to be comfortable dressed like that. But his verbal responses and his physical responses did not match what direction he was giving and what he was trying to do. So at one point, you know, he's told to lay down and he kind of tries to lay down, but then his words don't necessarily match that. He tries to say something back to the officer. And then he immediately gets back up. So he kind of appeared to have this brain body not talking to one another kind of interaction going on.
Kind of a responding to internal stimuli, didn't
Right.
seem to know what he's reacting to. And he's got one, he just has that kind of zombie look in his eyes that this something's off with this guy. So kind of did the right thing. He kind of got him to lay down. Unfortunately, he keeps laying down on his belly and then ran into traffic. So at that point, yeah, he's got to go hands on and get him out of traffic. And I'm sorry about the sound. I'll try to narrate the next section. I can't do the breaths.
Plug it in if that'll give it to them. Oh, no. See if that'll do it. Try that.
Yeah.
See if that works.
But let me know if you hear it.
No, nothing.
The other calling for medics. You hear him groaning and screaming. Okay. So did you hear it that time?
No, there was no audio.
Okay.
All right, we're striking out.
Yep. Okay.
No bug me.
I know.
So this one, they're trying to get him to sit up and he's fighting to lay down. So this is the right thing. You try to keep them up, keep them not on their back, but he keeps trying to go to his belly. They're still trying to get him to sit up. Tell him to sit up, but he's not. And he's screaming about lies and things like that. So for this is we're getting into the physiology. So clearly everything's increased: temperature, blood pressure, heart rate, and activity. When all this stuff starts going up, you start to need to blow off carbon dioxide more, which is where we get into trouble in the next one. So in this stage, what they're trying to do is they're trying to get him hogtied, which is something we've pretty much gotten away from. He's also pinned prone on his belly with a knee on his neck, all of which decreases respirations. So, you know, he's been writhing around, he's been screaming, now he's not. And now they've just realized that he's unconscious. They're calling for a BVM. And you can see he's still hogtied. Yeah. And saying undo the hobble if you have to. I think you're past that point. So how it works is the whole thing is in there. Contractions decrease your minute ventilation, which how much air is you're moving, leads to decrease in your pH, which is the increased acid in your blood, and then things don't go well. So how do we prevent that? One is have a plan of what you're going to do with these situations. We have this with our protocols, our combative patient protocols. If you get police and EMS going at the same time, so the dispatcher protocols can pick up that the patient is really not acting, the person is not acting right compared to just being belligerent, then maybe at EMS and police dispatch at the same time. Officer did this here, called for ambulance early on, and then protocols for sedation. And one part of this is having the docs on the other end of the phone understand what you're dealing with. So the big thing is teamwork, communication between police and EMS, communicating with the patient. At this point, though, I think communication with the patient is past. So physiology for restraint. Clearly, you're not restraining this guy. This would be easy. This is not who we're ever restraining. So what we have, restricted effects of restraints. Decreased movement. If they're on a prone, if someone's sitting on their chest, kneeling on them, decreased air movements. Compression of the vena cava, you have less blood flow, return to the heart, and fighting further acidosis and rhabdomyolysis. Rhabdomyolysis is something that I deal with. You guys are not going to have to deal with it. If you have them calm by the time I get to us, rhabdo is the least of our problems. No one's ever died in the ambulance from rhabdo. I can't breathe. If you say this in an ER 15 years ago, you'd have some grizzle nurse screaming back at the patient. Of course you can, you're screaming at us. But we have to remember now is that this isn't that air's not going in and out. It's that the amount of air that they're moving isn't enough to keep up with how much acidosis they have and how much they have to blow off. This is the air hunger sensation. If you ever hyperventilated yourself and watch your pulse ox go down into the 60s and you feel fine, that's because you're a calm and won't say intelligent person who was able to blow off the CO2 enough so that by the time your trigger for breathing kicked in, your oxygen level was a lot lower than it should be. These are not who we're dealing with now. So Eric Garner. This was the, so he was placed into a chokehold, which then he went unresponsive from. Everyone knows this one, but if you look at the footage for this one, there's not a lot of fighting going on. He's just laying there. This is not an agitated delirium. This is purely this is the position. And this one traumatized a lot of EMS because they're getting criminal charges for the care they give, and I'll use that term loosely. Why are we cycling this? Sorry, this was all playing right before we started. So here, assessment was done from 3 feet away standing. Even the cop had to tell the medic to back off and chill out a little bit. And then when you put him on the stretcher, he was flopped on prone. There we go. He was flopped on prone, and then the chest strap was tightened very tightly across his back. So this is the positional asphyxia. So why we're breathing, I hate to insult everyone, but basically there's 2 things. One is the inhalation, oxygen, getting the oxygen in. So that's your oxygenation. The other is actually to get the ventilation to get the CO2 out. This is what's the important part here. It doesn't take a whole lot of air movement to keep your oxygen level up. Asthmatics, we worry when they desaturate because it only takes like about a soda can of air for a minute to keep your oxygen level up. It's the buildup of carbon dioxide that takes so much air movement that we need. So it doesn't take much to cut that off to get us into trouble. So I'm going to give you some numbers that you guys don't check pre-hospitally, but we pay attention to here in the hospital. So pH up here, normal in a blood gas, 7.35 to 7.45. It's not a direct correlation, but think 35 to 45 for your end-tidal CO2 monitors. 8 is alkalotic, very alkalotic. Alkalosis is very difficult to get into quickly. So we usually don't deal with that very much in medicine, but acidosis is differently. 6.9 is really low. If you are hanging out in an ICU and someone tells the intensivist that the patient's got a pH of 6.9, they're going to be running over to that patient's ventilator and spinning dials to fix that, or doing whatever else they need to fix that, because that's not good. When you get that acidotic, things don't work right. Your brain doesn't work right, your muscles don't work right, and a big thing is your nerves don't fire right. So this is when you worry about having cardiac arrest and things like that. So we've established that 6.9 is a bad place to be for your patients. So what do? We take healthy police recruits and we make them do all sorts of stuff, and we check their blood gases afterwards. So these are a couple different activities. One is sprinting. We will pepper spray them, taser them. This heavy bag is full out boxing on a heavy bag for a minute. And then the next one is you fight the dog. So sprinting, pH goes down a little bit. This is not too bad. A DKA patient comes in with this. There's a chance I might be able to get them home today. So that's not too bad. Pepper spray really doesn't do much. You're all still pretty much in your normal range. Actually doesn't even touch them. Taser doesn't do very much. K9 doesn't do much. But if you look at the heavy punching bag, it goes 7.3 to 7.4 to 7.01. So you're just above that 6.9. We're really worried about you. And these are healthy, not cocaine intoxicated. not morbidly obese police recruits. So if you picture that level of exertion that's probably going on with this patient fighting us, that's where they're coming from. So that's part of our worry zone. Another thing we look at is the lactate. So lactate is a general measure of the stress of the body. If you have pneumonia, you come to us and we say you're septic and your lactate level is 4, whatever your blood pressure is, it doesn't matter. That is confirmed. That is called septic shock. So a lactate level of 4 in sepsis is shock. So a minute of punching the punching bag, lactate level of 15, and it stays up. Taser goes up a little bit and then starts to come down. Sprinting goes up, and pepper spray again doesn't do much to your lactate. So this is the, I get lactic acid when I run, so I get sore. That's true. But when you're healthy, you clear that. In these cases, this is how much exertion they're doing. So that's metabolically what the kind of danger zone they're in. So this was another one that was the arrest scenario. That was a 100-meter dash, climb a wall, tackle someone, and they got the pH of 6.1, a lactate of 7. So this is what you have to remember, that this is what you're trying to shut down when the patient's fighting you. Carotid restraints and chokeholds, even if departments are, do you know if anyone around here is doing these or?
So New York State has banned all carotid restraint except in deadly force scenarios. So,
Okay.
So no department should be doing that technically.
Yeah. So hopefully, unless you move out of state, you're not going to be seeing this, but some places would allow a carotid restraint, but not a chokehold. But you are 3 inches off of each other. And if you're in a fight with someone, it's pretty easy to slip from one into the other. So positional asphyxia, this is the position you're in. You can't breathe because you can't move your chest, and you go into respiratory failure with metabolic acidosis. So if I laid on my belly and for some reason you sedated me or didn't let me get up, I would eventually have positional asphyxia. If I was amped up cocaine, meth, synthetic cannabinoids, it's just going to happen a whole lot faster because I have a metabolic acidosis that you're now preventing me from compensating to with my breathing. So side position is always the safest if you can do this, but it's difficult to really restrain somebody on their side unless you have them kind of one up, one down and have them cooperating. So what's wrong with prone? So if you take healthy people, they got a 20% decrease in their ventilation just sitting there. If you prone someone in the operating room to do a certain procedure, it is very complicated how you do that. And it's like you're resting your chest, but your belly is hanging free, so it has room to move. So that's not something we have on an ambulance stretcher. So on their back is best. On their back is the best place to really treat them if they're not cooperative. So what happens when we do this? So this is your total lung capacity. This is your normal breath. This is your deep breathing. When you start compressing it, you end up pushing this total lung capacity line down to the point where pretty much they're just panting and they're kind of just ventilating this dead space here, which is not enough to blow off their CO2 or oxygen. So why would you restraints prevent harm to the patient, prevent harm to you? And once you decide that you're going to do it, this is not when you want to start negotiating. The time for negotiating is before the decision is made. Okay. So you guys are the ones who are going to do the restraints. You
got restraints.
You want to talk to me how you would do it ideally?
Can you guys hear me from the mics a little bit?
Yes.
Try it. Reach. So I'm to understand that our audience is EMS, paramedics, and EMTs, not police officers. I have that correct, right?
That's correct.
All right. So let me go back up just a little bit. So I can only speak to the Town of Colonie Police Department, but we do have experience with the Zone 5 Law Enforcement Academy, which does train most of our departments in our regional area. But I will say the relationship that's been built between our police department and our EMS department is not the norm. I'm trying to say that in the most fair way possible. So speaking to if you get anything out of what I'm going to say in the next minute or two, I would encourage you, if you're in a leadership capacity in your EMS department, to make contact with somebody in a leadership capacity at the police department and make a commitment to training how you're going to deal with agitated patients as a team. And so we've been using a backboard technique, which I'll go over shortly, but it really comes down to everybody knowing what the process is in both the police department and the EMS department. So if we're dealing with a known agitated patient that we know it's going to be medical right off the bat, we attempt to have EMS within arm's reach of us before we initiate any takedown at all. And our goal with that is because we know once we do that restraint, it could be life-threatening to the person that we're holding, and we want to have EMS there capable of initiating a chemical sedative for the person once we've got them held down. We want to minimize that as long as possible. So some of the notes here is this is maybe more if you're EMS or hospital staff, but I'll speak to how we do it in our police department. So here talking about 5 individuals, I don't know if that's realistic for your EMS departments, probably not. Maybe inside a hospital it would be, where this is the slides are from. But we try to do it as 2 officers. So I'll show you what we do. So this image is the person on the backboard is a hypothetical agitated patient who these 2 officers had already initiated a takedown of and have handcuffed them behind their backs. And so we've taught our police officers in Colonie that we try to make it very simple. So what's their cue to know if the person's just fighting with them and the fight's over, or if that fight is indicative of a more serious condition. And so what we try to simplify it, all we've taught our personnel is that if after those handcuffs go on, where you would expect somebody to submit and it be over, if they continued fighting, they continued yelling, or they continued tugging at the restraints, we've taught our personnel that is a medical emergency and they need a medical evaluation. So we'll put them in a recovery position on their side. If possible, EMS arrives. If we can chemically sedate them, if it's necessary, we let them take the lead. But how we transport them to the hospital is on this backboard, standard EMS backboard. So we slide it underneath the patient. We'll lift them up, 1 officer under his arm. The board goes under, and then we secure the legs first. The reason we secure the legs first is that's where all the power is. Once we go to lower them down, we want to take the legs right out of the fight. So that's the first step. Now we're going to maintain upper body control. So our officers are taught to maintain just a standard control hold here under both arms. And then we don't want the patient handcuffed behind their back anymore. So 1 officer is going to maintain control here, and they're going to remove the handcuffs. So if you can see, the officer on the right still has the arm and the hand. The officer on the left has the arm and the free handcuff, and that's going to go right to the board. So secured to the backboard there. Everybody, can you see that? Everybody's got that, hopefully.
Yes.
And then, yep, okay. And then, so once that arm is secured, then that officer who's maintaining the free arm, we're going to have 2 on 1. So 2 officers are on the free arm now. They're going to take out another set of handcuffs, handcuff that free arm to the backboard. The patient's still sitting up. And we have more images, but if the person's still fighting and won't go down, some of the police videos you'll see a bunch of cops and EMTs keep trying to shove the person down with their hands, and there'll just be this giant pushing match. What we've trained our officers to do, I wish I had the picture. They'll go back to this position and use their shoulders, and they'll post a hand on the head just to make sure they don't get bit, but they'll use their shoulder and weight on the patient's shoulder and just kind of lay into it and lay them right back down flat. And so you get into that position. We make sure that that strap across the chest is loose. We'll ask EMS to check it. Hopefully, we don't want that too tight. And for us, we believe that this provides a position. So it's got a hard, flat surface for CPR should it become necessary. The arms are in good position for IVs. And we've taped the head if it's necessary. If their head keeps coming up, we'll tape the head down. Can you advance that? Or maybe it's just, there we go.
There we go.
Okay.
Okay.
There you go.
Thanks. So chemical restraints, we've come a long way. When I started, we had 10 milligrams of Valium on the truck, which was for seizures, and you might get a doc to give you permission to maybe give 2 milligrams if they were combative. So you ended up coming with someone tied to the stretcher screaming and not doing very well. We've come a long way. We've got lots of tools available now. Physical restraints are there to maintain your safety until you can get adequate control medically. It's not enough just to get them tied down so they can't hurt you. Now you've got to keep them from hurting themselves. So a couple different medications we have: benzos, diazepines, all ALS services have them, antipsychotic and ketamine. A few less have them, but most are starting to head towards that now. So antipsychotics, Haldol, haloperidol, great medications that many people are carrying now. Smaller doses for elderly, and then 5 to 10 milligrams for most people. Droperidol may be coming out at some points. This is a beautiful drug that's a long story of big pharmacy messing with us for years, but now it's back and we love it. But it's not on the pre-hospital formulary yet. With haloperidol, you need to check the QT. So if you're giving multiple doses, you need to get an EKG on that. And we use it all the time for nausea and migraines. They work great. You just have to explain to the patient, no, we don't think you're crazy. It just helps your migraine. Benzodiazepines, right now we just have midazolam or Versed, which is probably the best choice in this situation. It is the best absorbed of all the benzodiazepines, IM, so you're probably not going to have an IV in most of these situations. So it's good that we do carry the one that's the best for it. Up to 10 milligrams for the takedown. It does have the more concentrated formulation, which sometimes goes in a short supply. And the nice thing is that it has a shorter half-life, so you get control of them, but they're not sleeping for 6 hours. So if it was a psychiatric issue, we can get them cleared and off to psychiatry today rather than waiting for 6-12 hours before we can do that. Ketamine has gotten a bad rap through the popular press. But ironically, anytime you show up with a toddler with a broken arm, they're going to get ketamine for us to straighten it because it is the safest thing that we can do. It comes on quickly, 1 to 5 minutes, where Haldol can take 15 to 20 minutes to take full effect. It is the only medication that does what it does. The beauty of it is it takes the part of your brain that makes you you and separates it from the part of brain that you share with a frog, and keeps that part going well. So you keep breathing, you keep ventilating, your heart goes fine, your blood pressure goes up a tiny bit. But that increase in the heartbeat and the blood pressure is completely trivial compared to it shutting down whatever else you have on board. In the year, we've all got stories of, I gave this person 30 of Ativan and 30 of Haldol, and they were still commenting on my gender and whatever else. And you gave 100 of ketamine and they were sleeping. So it's a beautiful drug in that respect. Whatever they took, ketamine will shut them down. You really can't overdose with ketamine. The only published toxic number is 40 milligrams per kilogram. And that's reviewed with the Albany med tox folks. They can't find anything else other than that. Because what happens is it shuts down everything that's pumping you up and it puts you back down to baseline. The only time you get into trouble is when you have a whole bunch of other sedatives on board that were being masked. So if they already took a whole bunch of Xanax along with their cocaine, and then you shut the cocaine down, now you're just dealing with the Xanax. That's about the only time you really get into trouble. So agitated delirium. If you were going to have a choice for a first line med, this would probably be it. If this is a someone who knows going to be a fight, they're really amped up, just for provider safety, because it's one shot versus going with Versed, going with Haldol, and waiting for it all to kick in. This is probably your quickest way to get control. Initial dose is 250, and then repeat 3 milligrams, 3 to 5 milligrams IM and 0.5 to 2 IV. Just remember that is ideal body weight. So if they weigh 300 pounds, but they're 5 feet tall, you may want to adjust your dose with that. One thing is don't hesitate with the dose, because ketamine has this wonderfully complicated bimodal drug effect. At really low doses, it works great for pain and anxiety. At really high doses, it disassociates you, which is where we want. And in between, you have the recreational zone. So if you do underdose it, you go from the patient who thinks he's fighting with the cops and the paramedics to they're fighting with aliens. So just think what that would do if you were in that situation. Okay, so just a very simplified algorithm of what to do. If you're fighting with someone and then they become unresponsive, if they're not responsive, they look at how they're breathing. If they're breathing normally, recovery position or deal with the airway as you need to. If they're breathing slowly, you may need to supplement with this BVM. I'm not going to suggest go to CPR every time you think they're breathing slowly, but they definitely need some ventilatory supports. And if they're not breathing, definitely check a pulse in situation. You're probably going to need to do defibrillation and CPR. If they arrest, consider this an acidotic cardiac arrest. So a couple amps of bicarb and some hyperventilation. And you probably don't need epinephrine, because I can guarantee you all the catecholamines in their body are probably already in circulation. So yeah, as we were talking earlier, anytime that they're not right and they're continuing to fight afterwards and they look like they're drugged up, this is when you want EMS involved. And naked patients are always an issue. The last person who got brought to be naked, nursing and everyone else in the department was saying, oh, you just send him out the door. Yeah, she ended up being an excited delirium and needed ketamine to finally calm her down. So yeah, most people are not naked on their own volition running around. So agitated delirium, excited delirium, this is a term that has been an issue with press and the public. The big issue with it is no one else in the House of Medicine sees it besides us, as in us EMS and the ED, because there's 3 things that happen if you have it. You either go to the ED and you get cleared medically and see psych or walk out, you progress and die, or you go to the ED, you get cleared and you go with the police. So no one else sees excited delirium continuing, so it's hard to get the people upstairs to believe it exists when they've never seen it. Basically amped up, hyperstimulated, hyperthermic, like toxicology hot, 104, 105. We were just talking, the Gold's Gym guy from about a decade ago was 107 degrees in the morgue. So he was higher than that before they were able to get him controlled. And behavior-wise, yes, toddler with a temper tantrum, but an adult and high. So this was the junk science. It's not junk science. It's just, unless you've been there, you're never going to believe it, and we're never going to be able to study. It's the There is no evidence that if you jump out of a plane at 10,000 feet, a parachute will help you. It just doesn't exist. There are no randomized control trials. And this is something that we will never have good data on. So the best thing we can do is push for preventing positional asphyxia, to try to focus on the ones that are a medical issue that do require sedation and management. So some things that go into it: pre-existing cardiomyopathies versus acute cardiomyopathy from the drugs, metabolic acidosis we talked about, positional restraints. So when you're dealing with the metabolic acidosis, positional restraints even more important. And just shutting down all of this to get them calm and quiet, so then we can get them through the situation. So one of the latest ones, Elijah McClain, he was given ketamine, but when you look at the body camera footage, he was not really fighting much at the time. So unfortunately, ketamine is kind of the bystander to this. Okay, so this comes down when you look at a lot of these cases, it's the medics knew the medicine, the cops knew what they were doing, and it wasn't talking. So police can suggest anything, but depending on what you state you're in now, the police can't even suggest that. But they can't actually do anything to the patient. That's EMS's responsibility. Some pointers: so midazolam, fighting against restraints. Haldol, if you're older. If it's seems to be more psychiatric induced, then Haldol may be more useful than the midazolam. If it's more drug induced, midazolam is probably more useful. If you can't tell, it's probably going to be a both of them. And then ketamine, if either those are not working or it just looks like it's gonna be a fight up front, and that's what you want. So take-home message: public health emergency. It's all over the country. It's been going on for years. It's just everyone has cell phones now, so we're getting more videos of what's happening, whereas years ago it would just be, you would have a few deaths here and there, and you had a whole lot of people that came in, got treated, and went home. Teamwork with law enforcement and EMS. Big takeaway from these cases is, if you are sedating, they need to be monitored. These are for the comment of ketamine is, oh, it causes more intubation. When they did that study, they came in and the EMS people doing the study didn't really communicate with the ED. So you come with an unresponsive patient to the ED, they get intubated. And then they realize that this is the same as us giving ketamine here. So they just treat it like a sedation. And in a sedation in the ER is full monitoring, pulse ox, EKG, end-tidal CO2, completely focused on their breathing and perfusion. Everything goes well, it's boring. They get sedated, they go in, we watch them for a couple hours, and they go where they're gonna go. If it goes badly, acidotic, hyperventilate, bicarb, restrain early, give the medications up front, get them calm. Okay, and just reviewing this again, once if they're fighting you and then they stop, you need to pay real close attention to what they're doing, because if they've been fighting for this long, they probably just haven't decided to give up at this moment. It's more that something bad happened that's making them give up. So again, rule out medical threats. When you can get close enough, check a blood sugar, check your pulse ox, get your medical history. Don't put them prone. And as long as they're fighting, you need to keep redosing. Please, if you run out of what the protocol says, keep calling for more. Because as long as they're fighting, we can get in trouble. I had a patient who was literally asleep that was signed out to me as just waiting to wake up. And he was kind of absent-mindedly just pulling against the restraints as he was barely conscious. And he was in rhabdomyolysis and he was acidotic. And this guy was not outwardly fighting. He was just in the bed, kind of rolling and pulling against the restraints. So until you have them calm, we're not done. Okay. So before we get into cases, anything you guys want to add to any of that?
Want to stress too, that you do establish those relationships with law enforcement. I know some localities work with sheriffs, state police, and local law enforcement. Get them together if you have the connections to do that. You know, we are definitely the very lucky exception to have a very good working relationship. EMTs and paramedics train with the police to put people on the backboard. It's not just us putting people on the backboard. It's not just police putting people on the backboard. We work very, very closely together. You know, if we get up to a scene, if we've been staging and the police ask for a backboard, that means that the paramedic is drawing up drugs while the EMT and the police officers are putting the patient on the backboard so that everything is ready to go. Because if they're going on the backboard, 9 times out of 10, they're going to need that sedation. So it all kind of works together when you practice with it. So
No, yeah, no.
So self-explanatory, very large, very combative, very altered. And whoever he's holding, that could be whoever you want, that's it. Another EMS provider, that could be family member, whoever, but how are you guys approaching this guy? Clearly, he's not already restrained.
Yeah, he's not restrained.
strength in our numbers, so we're gonna get a few more people there. Try and get whoever that person is someplace safe, and again, have the drugs ready and kind of get him into a place where at least we can get maybe that arm or better a leg or glute to give a lot of medication in. And
What medication are you leading off with? What are you pulling from your drug box?
I would always go with ketamine first in these types of, when my safety is at risk, it's gonna be ketamine. When I'm just looking to keep them safe and make the transport safe, then it's gonna be a little bit more of a thought process. But if it's me and another option, it's going to be me and ketamine.
Okay. Any thoughts of how you're gonna get it so that she can give any meds to this guy?
Yeah, so just to reiterate, we try to wait to move till they're ready, right? So if we can, if nobody's safety is at risk, we're gonna try and just make sure we're all ready, and then we'll initiate. We train a lot more than other agencies do, but our officers would just initiate this takedown or a taser perhaps on this guy, and then we'd hold him we'd restrain him physically for as short a time as possible until they could chemically administer the drugs. That's how we would do it.
Okay. And again, I wish we were in person so I could pull if anybody knew who this person was. Okay, so now you have this guy. You show up and he is thrilled that the cops are there because his daughter, who he is calling his wife, says that he wants this crazy old lady who won't leave his house, and thank you that the cops are here to take him out. Meanwhile, she's got a broken nose that he just gave her. And this is ironic, but I think in the 1940s, there were no tall women. It is always a 6'4" old guy, and the wife is always 5 foot nothing. So when they say they don't feel safe, I can understand why. So he's agitated, but he's not throwing punches. But he clearly can't stay.
This would be one that we kind of start with verbal de-escalation to see if we can get an idea of what's going on. Maybe find some cues around the house as to if there's any medical conditions we need to worry about. And depending on his level of cognizance and or delirium, maybe convince him to come outside for an evaluation too.
And he's unfortunately, and this happens so with dementia, that they have dementia and nothing else. He is completely, this guy is still splitting his own firewood. He's still carrying it. But no, he wants this crazy lady taken out of his house. It's his right to be here, and his wife, pointing to his daughter, wants her gone.
So this might be, a little bit of help from the police department with physical restraint, a dose of Haldol, and some time to let it kick in until we can safely and then weigh if we have to put him on a backboard or not, or if the Haldol will put him in a better place where we can just secure him to the stretcher.
But hopefully he is, you can probably give him medication, step back and hang out for a few minutes.
Yeah.
So unfortunately, so this is you get called for an ALS intercept. The ambulance is parked on the side of the road, you come in the side door, and this is what you see. And you hear very loud screaming, making no sense. And he quiets down, and then he does that again. And the EMT tells you that we think we have a pulse, and it's really, really, really fast because the pulse ox won't read. And every time they try to take to feel it, they get like 3 seconds, and he starts ripping his handle. So he's already restrained. Now, what do you want to do?
Well, since we're on the side of the road, he's getting restrained to a backboard. He's undoing all of that, straps. We're putting a backboard underneath him, securing him the way that we prefer him to be secured. He's going on end title, see what his end titles are at, and see if we can figure out a metabolic way to treat him, and or if we need more sedation. If he hasn't gotten any already, we'll go from there.
I'm trying to scroll through the chat on 2 different screens. Okay, and here's probably the most complicated of all of them. Every once in a while, you get a first responder, either police, fire, EMS, that just seems to enjoy the fights. And I have a feeling that when either you are on scene, your respective agencies are not displaying that characteristic.
Right.
But every once in a while, you just get that. So you get an away game, and you get a different law enforcement agency that just seems to be spoiling for fights. How would you, and it's different for every situation, do you have a general approach to kind of diffusing your co-responder to not cause a problem? This is they're screaming at him, but they're yes ma'am to you.
So only happened a handful of times, but to me, the best way to explain it is I can help you help him if we just do it this way. You know, it's not necessarily that you're doing it wrong. Hey, this guy's an asshole. I got it. But I can help a little bit more if we just do this real quick.
Mhm.
And it's worked so far. I don't want to jinx it, but and I think it's important too to realize that we're human. If I get there with an agency or an officer that I don't know, and he's been fighting with this guy for 20 minutes by himself, I'm sure that he's got a lot of adrenaline. I'm sure that they have a lot of adrenaline, whoever it is, you know, just as amped up as they rightfully should be as a human being, that they've been fighting with somebody for a long time. So you do have to kind of break through that a little bit too. And it's the same thing with EMS providers. We all want to go home, and if we've been fighting with somebody, waiting for a police officer to get there, somebody's busy and we get, you know, an officer that we're not, or a department that we're not familiar with, there's a little bit of a couple moments of getting to know each other quickly, but ultimately it's getting back to baseline and saying, I need this done. Can you help me do that?
If you get Nowheresville ambulance, because they're all tied up. And
Sorry about
they're
that.
like, yeah, just strap them down. You're nothing else. They're ripping the cuffs off, cutting their hands, trying to get out of it. And they're just, yeah, whatever, time down.
I think we just approach it the same way. Our personnel are really good. They're going to do their best to de-escalate the EMS worker too. And I think we're going to circle back. We're just trying to do the best for the patient. Try and get them a timeout, try and redirect the public safety personnel that are not contributing to the benefit of the group somewhere else. That's all. We just try to do our best.
Yeah, you guys should all be proud of yourselves, because as far as the public relations battle goes, you are way ahead. Try to Google clip art for an angry cop and an angry paramedic and make a comparison of the options you get. That was the only angry face I could get. So this is just the drunkicidal guy. He's been at the bar, hasn't been anywhere else. Fred says, yeah, he doesn't do anything else. This is purely just drunk and angry. What are your thoughts? He took the bottle out of his hand.
Yeah.
No
He took
bottle.
Being safe, BSI.
Yes.
Now, these are particularly a little bit more difficult because even if they are of sound mind when they're not drunk or when they're sober, it's tricky, and you know, we've all had one too many, to say the least. But if you can't get him back to a place where he's reasonable, then I don't like to argue with too many people for too long, especially children or drunks. So
Yes.
I'm a big fan of sedation. This guy would get at least a couple milligrams of Versed
Okay.
to compliance.
One tweak also to think about is Versed and alcohol hit exactly the same place. So what you're doing is we fix them by making them more drunk. So if you do have Haldol, that might be a chance to use that, because then you're controlling their behavior and they're just going to metabolize the alcohol. But Versed will definitely work and fix the situation for you. Okay. I think that's it for our cases. I'm going to ask any questions when we get out of this so I can read the chat, because I can't do it at the same time on this. Any questions?
Any questions? Put them in the question and answer or the chat. I mean, we got great resources for you to ask some questions.
All right, if there are any questions, can you let me know? Because I cannot get my mouse to go over to the chat bar here. This is antique, so it's on touch screen.
It is antique. It's municipal.
Yeah. Asking about Versed intranasally versus intramuscular when there's no IV. Is that the preferred way?
I would do IM over intranasal. Seizures, absolutely, you could do it. And it's also off protocol to do it intranasal. And if you spritz up someone's nose, you're just going to get it spit back at you. And it's a lot easier to restrain a thigh or an arm than to hold their head still and get your fingers close enough to get bitten. And I saw a comment of Versed and Haldol. Absolutely, if you get orders for it appropriate, that's basically what we would do. It's sort of your goal is the Haldol, but the Versed acts quicker. So it gets control of them a little bit faster. And then when the Verseds metabolize, the Haldol is on board and they're staying calmer.
Yeah, that looks about it. If there's any other questions, I'll forward them to you. But
Okay.
thank you, the three of you. Appreciate it.
Thank you.
Thank you.